Good afternoon, everybody. Welcome to the Iowa Ortho Project B.E.A.T Osteoporosis Month presentation for Thursday afternoon. My name is Dudley Phipps. I'm the director of the Bone Health Unit at Iowa Ortho in Des Moines, Iowa. Hopefully we will have an educational period of time here. Just a reminder, if you would like to ask questions during the interview or during the webinar, the email address is marketing@iowaortho.com. Today's topics, that looks like last time. Nutrition for healthy bones, and what's the connection between osteoporosis and arthritis. And I promised everybody last time we would also talk a little bit about osteoporosis medications. Before we get started today, there were a number of questions that came in last week after we signed off, and I'd like to address some of those before we get going too far. There were a number of questions regarding exercise and osteoporosis and how that relates to osteoarthritis. Now, osteoarthritis, for those of you with arthro, you know that that is a pain problem. And a lot of times the osteoarthritis or even rheumatoid arthritis prevents you from doing what we would consider normal activities because of pain. So, things that you can do with vertebral compression fractures if you have arthritis, if your knees, hips, shoulders, all of those limit your activity levels and really sometimes restrict the things that you can do as far as exercise. In general, walking is good exercise for osteoporosis to help keep your bones healthy. It is also good exercise and often is something that can be tolerated by people with arthritis. Weightlifting, and you don't necessarily need to go to the gym. I'll often have people get small weights to use at home, get cans of vegetables out of the cupboard, a half gallon of milk, whatever you have that provides some resistance or some weights, and lift weights. If you can only do this with your arms, do it with your arms. There is absolutely no right or wrong answer other than being sedentary is bad. And being sedentary or limited activities is not only bad for osteoporosis, your bones, it's bad for your joints, it's bad for your heart, your lung, your everything else. So exercise in general is important for people. There was a question about how much calcium should somebody take in a normal adult diet. And typically, for women over age 50, we consider about 1,200 milligrams of calcium a day to be the normal dosing. Now, that is not necessarily 1,200 milligrams of calcium supplements. That is 1,200 milligrams of calcium in your diet plus your supplements. So things like milk, cheese, cottage cheese, yogurt, nuts, beans, dark green leafy vegetables are all good dietary sources of calcium. Now, how much calcium pills do I need? Well, you kind of have to look at what are you eating and figure out how much calcium do I get in my diet, and do I need supplemental calcium? Most multivitamins, especially the over 50 vitamins, have calcium in them. Look at the bottle and see how much is in there. You can take calcium pills if you need to, but I'm not a big fan because most people get enough calcium in their diet to manage their calcium needs. Foods that are great to eat for bone health. Really, variety is the spice of life. Should have a balanced diet of fruits, nuts, vegetables, proteins, carbohydrates, fats. Really, everything in moderation is good for you. There was a question about bone density testing, and I'm going to go over that real briefly here. But I'm going to do that towards the end. We're going to talk about a couple of other things first. Jaron, does that look like? That looks like we've hit most of the questions from last week. So let's kind of plow in here. Nutrition for healthy bones. Again, my nutrition talks are fairly limited in scope because a person needs calcium, main building block of bone. We've talked about that a little bit. Look at your dietary sources. Often, dietary calcium is much better absorbed than calcium supplements. And calcium supplements will also cause constipation, diarrhea, GI upset, things that really are not what we're looking for a happy life. Person needs vitamin D. Vitamin D helps metabolize or move the calcium through the body, and that's part of the calcium transportation system. Most adult males have about 1 pound of calcium in their body. All but about a teaspoon of that is stored in their bones. So women have a little bit less than 1 pound of calcium. But again, most of the calcium should be stored in the bones. Vitamin D helps pull the calcium out of the foods you eat, drags it up to the blood. You need more vitamin D to get it from the blood up to the bones where it should be stored. Sources of vitamin D. There's a little bit in milk, a little bit in a mushroom, a little bit in an egg. There's a lot in fatty fish like salmon, tuna, sardines. But most of your vitamin D comes from sun exposure. A person needs about 15 minutes of sun, depending on the source that you look at. 15 minutes of sun with the majority of your skin showing. So imagine yourself in a swimsuit or a bikini for about 15 minutes every day. Now, if you live in Iowa and you go out in December in your swimsuit, something's going to freeze off and your neighbors will probably talk about you, and you're still going to be unsatisfied with the amount of vitamin D you get. So vitamin D is one of the things that I typically supplement. I typically utilize over-the-counter vitamin D3. Dosing depends on what your baseline vitamin D level is, and you should talk to your healthcare professional to make sure that they're understanding what the requirements are. I'm big on measuring. I can guess what your vitamin D requirements are, but it's a lot easier to measure and see how much vitamin D you have and shoot for a target range. Vitamin C is important for your bones. Bones have collagen. Bones naturally have some springiness or elasticity to them. And the vitamin C helps keep your collagen healthy. Now, other nutritional things, and some of these fall under habits, some of them are nutritional. Smoking is one thing that we always talk about. Smoking tends to make bones soft. So something that we find when we're in the operating room, soft bones tend to break easier. They tend to heal more slowly. They tend to be more challenging to get them to stay in place, so they will heal, either after a broken bone or after an elective surgery. So smoking to any degree has adverse effects on the bones. Alcohol. Remember I told you most things in moderation are fine. For a woman, 1 alcoholic beverage a day. For a guy, 2 a day is considered moderation. And if we talk to the heart doctors, they think that a little bit of red wine is very good for your heart. Drink of choice, your call. Weight-bearing activities. Again, we'll go back and kind of review what we talked about last week. Bones need to have weight on them to stay healthy. The magic number in the osteoporosis world is about 127 pounds. So as an adult, you need at least 127 pounds of force on your bones to maintain a healthy skeletal system. If you have less than that, you tend to have faster reabsorption of bone, or you tend to lose bone faster than somebody that is a little bit heavier. Fall prevention is critically important. We talked last week, nothing good ever happens if you fall. So, if you need an assistive device, a cane, a walking stick, and I'm very big, my patients will tell you I'm very big on walking sticks because they seem to be a more natural extension of yourself in order to help you walk and have more stability. I'm okay with a walker if that's what you need, but I don't ever want you to fall. So part of that fall risk is how's your balance, and how's your strength. So we go back to what can we do with arthritis that doesn't hurt my arthritis and make me miserable, that I can still do exercise. So, perfect world, yoga, low impact, good for your bones, good for your heart, your lungs, your muscles, really helps everything. It's exceedingly good for balance. Swimming, good for your heart, your lungs. Doesn't do much for your bones because you're weightless whenever you're in the water. Weightlifting. Remember, if you lift weights, and that's any kind of a weight, be it a 16-ounce can of pork and beans, or be it a barbell, or even resistance training, the more you do that, that weight transfers from your fingers where you're holding the weight, through your arms, down your spine, and if you're sitting, it doesn't go down to your legs. If you're standing, it goes clear to your feet, because the weight you pick up transfers to whatever you're on, be it sitting or standing. Those things are good for your bones. Again, moderation is key here, because from an arthritis standpoint, excess weight can be damaging to your joints. Now, the connection between osteoporosis and osteoarthritis, that's always an interesting question. Imagine my arm here. Elbow's here, wrist is here. If I get arthritis, the cartilage in the elbow wears out. And instead of being like an egg gliding on a Teflon frying pan as I move my elbow back and forth, it becomes painful. It becomes like sandpaper, gritting and grading on sandpaper. Now that's an overly simplistic evaluation of what osteoarthritis does. It is a loss of cartilage over time. Now, arthritis is a joint process. Osteoporosis deals with how strong are the bones between the joints. And whenever I worry about breaking something, I'm more worried about the osteoporotic nature of the bones, not necessarily the joints. And they're actually two separate yet integrated components that work together, but we treat them as separate entities because the treatments for both are quite different. Now, one of the things that I wanted to make sure I got to today, how do we treat osteoporosis, but more importantly, how do I reduce my risk of breaking something in the future? Now, this is a good place to start in on what risk factors look like for osteoporotic fractures. Well, the one that most people are familiar with is a bone density test. Most bone density testing, at least DEXA scans, which are the gold standard of testing, according to the International Osteoporosis Foundation, the measure of scoring is called a T-score. Basically, we look at how much bone you had as a young adult. For a woman, somewhere around 20. For a man, somewhere around 30. We've done studies of tens of thousands of people to find that one size average of what you should have had whenever you were a young adult. And a T-score basically measures you against how much bone you should have had as a young adult at peak bone mass. If you have more than a 2.5% or a 2.5 unit deviation, which for those of me that is not a math major, that's about a 25% change in the amount of bone from peak bone mass to whenever we measure you. A loss of 25% constitutes a test result that says osteoporosis. Now, that is a test result. That is not a diagnosis. But your bone mass, how much bone you have, is a critical piece of calculating what is your risk of breaking something. Other factors that go into this, your sex, your age, weight, do you smoke, do you drink, underlying medical conditions such as rheumatoid arthritis or taking oral steroids or inhaled steroids also increases your risk. Factors such as previous cancer, chemotherapy, radiation, vitamin D deficiency. There's a number of other things that go into the calculation on some of the risk calculators to determine what your risk is. Now, there are two primary calculators that are used, at least in my clinic. The first one is FRAX. You can Google this. It's capital FRAX. It is from the University of Sheffield in England. They have calculated based on different ages, different weights, all of those risk factors that I talked about. What is your risk of breaking a bone in the next 10 years? Or what is your risk of breaking your hip in the next 10 years? And we plug in a multitude of things. It gives us a score. And if you score above a certain level, we feel that you have an increased risk of fracture. The other scale that I use quite often is a scale called Gervin. Now, Gervin is an Australian scale that looks at age, sex, the amount of bone, so your bone density reading, the number of falls you've had in the last year, and the number of broken bones you've had after age 50. The Gervin scale gives you a 5-year and a 10-year risk of any fracture, as well as a 5-year and a 10-year risk of having a hip fracture. Now, the other thing that we look at is, have you broken a bone? If you broke something, how did you break it? Was it a simple slip and fall, or did you fall off the garage roof? If you fell off the garage roof, probably should break something. Be more careful next time. Don't fall. If you just had a slip and fall, almost every bone in the human body has a risk for a relative amount of time. So for example, if you break your hip, you have about an 80% relative risk increase in another hip fracture in the next 2 years. Likewise, other medical conditions like a heart attack. If you have a heart attack, you have an increased risk for a cardiovascular event for about a year after that. So often the body has some risk. If you have a major event, the body has some risk of having that same event within a given period of time, and broken bones are no different. Now, we do all of these calculations and come up with some kind of a risk. And if your risk is high enough, there are things that can be done to reduce your risk. Now, overall, in order to reduce your risk, you can either modify activities. Well, if your activity was a broken bone, I can't really unring the bell. However, if your risk is you have this much bone, well, we can reduce your risk if we increase that to this much bone. And that often is the biggest area that we can change your risk of a fracture. So by increasing the amount of bone, your fracture risk decreases. The body is always doing two things, and it's doing two things from the time you're born. It's building bone, and it's losing bone. And last week we talked about you build bone at a very accelerated rate until you reach peak bone mass, which for a woman around age 20, for a man around age 30. And then after that, you slowly start to lose bone faster than what it's built. So we have a multitude of medications available in the osteoporosis world to either build bone extremely quickly or to slow down the rate that you lose bone such that the body will build faster than what you lose. Now, I'm going to talk just a little bit about these bones. I'm going to preface this by telling you that this is not an endorsement for any of these products or any of these medications. All of these should be done in consultation with your healthcare provider. So basically, osteoporosis medications that build bone are called anabolic agents. There are, I'm going to say, 2.5 of these right now on the market. The first two work on something called parathyroid hormone. Okay, your parathyroid is 4 little glands in your neck. Each one's the size of a grain of rice. Their two primary jobs in life are manage where calcium goes. Is it going into your bones or is it going out of your bones? And they also manage phosphorus, which is fancy speak for they manage kidney function. So the two products, Tymlos is trade name, Forteo is the other trade name. Both of those are exact mirrors of the first half of the parathyroid hormone. And they're the half that says, I want you to build new bone like gangbusters. They both form new bone cells, and they're both an injectable. You get a shot a day for 18 months to 2 years. They build bone like gangbusters, and they build new, what we call bone forming units that eventually take and they tear out bone a little more efficiently, but they build bone and store calcium very, very efficiently. Those medications we typically consider will reduce your risk of breaking something by about 70 to 80% over the course of the time that you're on them. Now, upsides and downsides, both of these have a warning that they were shown to cause or thought to cause something called osteosarcoma in laboratory rats. We've not seen that effect in humans, and these medications have been out for more than 20 years. We've got a lot of experience with them. In general, they build quite a little bit of bone at the spine, not so much bone at the hip, and sometimes we'll even see some decrease in the amount of bone at the hip over the course of treatment, just in the way that they work. Both are relatively expensive. And again, more details from your healthcare provider. Now, the newest medication that we have out is a medication called IVenna or DiNozzoMob. And I'm probably butchered the name on that. This is a medication that works on a bone hormone called sclerostin. Now, sclerostin is something that the bones build or throw out from a very young age. Sclerostin is thrown off the cells that build bone, and it causes the cells that build bone to be more active. And in the absence of sclerostin, the bones don't tear down very much. As we have more birthdays, we have more sclerostin, and the sclerostin builds, which causes the bones to build slower and to tear down faster. And that process continues throughout your life. So what IVenna does is it grabs that sclerostin. It allows the bones to build very, very quickly, and it will build very robust amounts of bone when we measure at the spine and when we measure at the hip. This is a 12-month treatment course. It's 2 shots once a month. It's been out right at a year, so it's having its first year anniversary. Another medication. So sclerostin not only controls how fast you build bone, it also affects the speed that you lose bone. So it does both anabolic and what we call anti-resorptive treatment. Now we're going to get into all the medicines that, in essence, slow down the rate that you lose bone, or they are called anti-resorptive medications. First one on my list is a medication called DiNozzoMob Prolia. An injection once every 6 months. This medicine works on something called rank ligand. Rank ligand is something that's created from bone cells that build bone. They spit off this rank ligand, which eventually forms the cells that tear down bone, the osteoclasts, and it grabs that rank ligand, so there's not that cascade of building new cells that tear down bone. I build faster, I tear down much slower. That medication's been out a number of years. There's good relative long-term data, 10-year plus studies to show safety. The next group of medications I would talk about is what we call bisphosphonates. Bisphosphonates have been out. Some of these have celebrated their 50th anniversary this year. medicines that most of you may have heard of: Fosamax, alendronate, Bonita, Reclast. These are all in that same family of medications. These are medicines that are taken by mouth once a week, once a day, or once a month, depending on the medication. They basically throw a blanket over all the processes of bone, so the bone doesn't build much faster, but it certainly doesn't tear anything down. Upsides of these medications, they last for a very, very long time. Often if you take them and they're effective, if you take it for 5 years, it'll stay in your bones for maybe 5 or 6 or 7 years after you take it. That's good because that means you can take a drug holiday. You can stop taking it at some point and the medication effects will stay. Now, these medications, and actually all the medications that slow down the rate that you lose bone, are trying to store calcium into the bones to make them stronger. And when they do that, they have to push out collagen. So I always lose some amount of that bend that I have in bone. So one of the differences between all these medications is what part of the bone do they put collagen into. The bisphosphonates tend to put it into the outer ring of the bone, and one of the known complications, very, very rare, is a condition where you get brittle bones. You get what's called atypical hip fractures. As you walk, and that thigh bone should bend a little bit with each step. As you're on these medications for a number of years and you push out the collagen, that bone can become very, very brittle, like a bar of glass, and it can snap. There's also an IV version of these medications called Reclast. That is medication you get once every year. Again, very, very long, what we call half-life. Stays in your bones for a very long time. So, we still use those medications. Not bad medications, just a different set of side effects that have to be brought into the equation to worry about. The last group of medications that I'm going to just briefly touch on is hormone replacement treatment, estrogen replacement, testosterone replacement. These have been around for a long time. As you have more birthdays, replacement of those hormones comes with their own set of side effects, but they all are protective for the bones. Now, a question that I often get: how long do I have to be on medication? One of the things that we look at this point, there's a lot of research that's been done that says if you get to a certain amount of bone, that's where we think that your risk of breaking something is the best we can make it. So often what we look at is the measurement of T-score called the femoral neck. That's part of your hip measurement. And what we want it to do is go up 1 standard deviation unit from where it started. If you started between 0 and minus 2.5, or in the normal or osteopenia range, I want it to go up 1 full number closer to 0. If you started at minus 2.5 or below, I want to get you up to a minus 1.5 for a T-score. Because we think, and there's research coming online now that indicates that once we get to that point, we've done everything we can. So part of the trick is, whenever we're talking medications, I want a medication that is strong enough to actually improve the amount of bone that you have to get you to the target. Something to discuss with your healthcare provider. Are there any questions coming in?
Mm-hmm.
Oh, good.
How much coffee can I have per week? I use dark roast with a Keurig coffee maker.
So the question is, how much coffee can I have per week? And does it make a difference if it's decaf, dark coffee, light coffee? Remember, everything in moderation. I don't have a big concern with coffee and your bones. It does not seem to affect your bones. There's a number of studies, and up front, I am not a gastroenterologist, but there are studies that seem to indicate that coffee reduces your risk for certain colon cancers. Again, talk to your healthcare provider. I would not have any limitations on the amount of coffee, But again, I don't know that this is necessarily the thing that I would worry about the most from a bone standpoint.
Please address what exercise is appropriate for the thoracic.
Okay, another question about exercise. What exercise is good for my thoracic spine? So in other words, from the base of my neck really to my low back, what can I do to exercise my back? There are a number of stretches, a number of exercises that you can do. Again, let's start with what are your limitations? Well, pain is a big limitation. Okay, I don't want to do things that necessarily hurt. And everybody has a little bit different point as to what their capabilities are whenever they start. If you have a lot of compression fractures in that area of your spine, often turning, twisting, leaning forward or leaning back causes pain. Okay, and if you have a new fracture in that range, leaning forward or leaning back can increase your risk of making the fracture worse or developing another fracture. So this is something I would talk to a physical therapist, but in general, remember the things that your parents told you when you were young. Stand up straight. Don't do things out here. Imagine if I had a 5-pound bag of sugar and I held it up next to my body. Doesn't weigh very much, but the further I get that out, the more it weighs and the more stress that puts on my back. So try to do things that are closer to the core.
When you say 300 heel strikes per day, is that heel to toe walking, or does it need to be more forceful, like jumping or running?
Okay, so the question is, we talked about heel strikes last week, and especially in children, 300 heel strikes a day is what we would expect for a child to have to develop peak bone mass. So the question is, as an adult, what is a heel strike? So a heel strike is exactly that. When the heel of your foot hits the ground, that's the heel strike. The rest of what we call your gait, where you push off with the ball of your foot, that's a normal stride. That's the normal walking rhythm. But every time your heel hits the ground. Now, if I walk, I don't have a hard heel strike. If I run and I'm actually, one foot's in the air and the other foot starts in the air and then there's this pound down, that's a firm heel strike. But keep in mind, what are your limitations? I don't want you to hurt yourself. Do what you can do. Walking is easier on the joints. It's less impactful for your arthritis. It's better for your bones. So everybody has to have some give and take. What can I do within my activity level and my pain level to optimize things? I don't want to make your pain worse and have better bones, because then all you're going to do is sit and take pain medicine.
Can you talk about algae cal?
So the question is forms of calcium. Algae cal was the specific question. I'm not that familiar with this product. There are a multitude of different calcium supplements, different sources, be it from algae, be it from elemental calcium, be it from oyster shell. All of these calciums, from an element standpoint, pure calcium is pure calcium. I'm looking at what is the delivery method. I'm a big person on eat the right things. See what you need in your diet. Do the things that you can in your diet that really aren't awkward. I don't want you to have to hold your breath and do something that you don't want to do every day. Everybody here eats, though. Eat the things that are good for you. Look and see what foods have calcium, how much calcium they have, and try to eat things that are good for you that also bring you happiness in life. And that's all the questions we have right now. I'm sorry, I took my glasses off, so I have to squint. We'll give another minute here for questions. We're going to kind of wrap up here, though. I want to thank everybody for tuning in today. This is National Osteoporosis Awareness Month. We want to do as many things as we can to get people to identify risk factors for breaking something and take action. Some of you might have noticed the Project B.E.A.T on my shirt this week and last week. B.E.A.T is something that we developed here at Iowa Ortho. Be educated, aware, and treat osteoporosis. And sometimes treating osteoporosis does not necessarily mean a medication. Medications are appropriate if you have a high enough risk. Otherwise, we look at things to optimize the health of your bones. Do you have enough protein in your diet? Very important for bones. That builds the basic framework that holds the calcium for your bones. Do you have enough vitamin D? Do you have a system that is efficient in your body to absorb absorb calcium out of your gut into your blood and to get it from your blood to your bones where it belongs? Is your parathyroid glands healthy? Is your thyroid healthy? Is your kidney function appropriate? Is your liver working the way it's supposed to work? What's your magnesium levels? There's a multitude of things besides medications that go into how healthy bones are. Oh, one more question, then we're going to call it an afternoon here.
You spoke to eating healthy foods, but are there foods that pull calcium out of our bones?
So the question is, are there foods that pull calcium out of your bones? I've looked at this at length. In my opinion, moderation is the key to life. There's some studies out there that would say coffee is bad for you, and for those of you that are starting to sprout a gray hair or two, you remember back a number of years ago, coffee was bad, eggs were bad, bacon was bad, everything that had taste was bad. Well, fast forward 20 years, chocolate is a good antioxidant. Coffee seems to reduce your risk for certain cancers. An egg a day, the heart doctors are okay with an egg a day because it seems to be good for your heart. So in the medical community, studies swing from one side to the other. We're living in the world of COVID. You've noticed everything that has changed over the last 3 months. Don't wear a mask. Wear a mask. Wash your hands. Don't lick a doorknob. There's a lot of things that we've learned here in the last 3 months that have changed somewhat as we've gone through this. So, moderation, talk to your healthcare provider, take good care of yourself. Okay, I want to thank everybody for participating. If anybody wants to dial in, we're going to plan on doing something like this again in October. We'll try to get the word out early enough that people can participate. Thank you very much for participating and have a great day.